Hi guys, this is Vicky. Let's take a look today at managing a team. So the first thing I want to start with is that, really leadership does start with you. You are going to be the nurse that you choose to be once you leave nursing school. Maybe that is at some point in time, maybe you will be a formal leader. However, as you first leave nursing school and enter your first job, you will be an informal leader. You will be working with others to ensure the success of your nursing team, making sure that the nurses around you are also staying successful on your day. But you will be the leader of the nursing team for which you're caring for. You will be the leader for the CNAs who you're working with, for potentially the RNs that you're helping out with. And then maybe at some point you will take on a formal leadership role, maybe in the form of a team leader, or maybe at some point a manager or director. But I want you to know that even today, leadership does start with you, and you are influencing others, you are directing others, you are making that positive impact to ensure that your nursing team, your patients, are successful through you, with you, and through you throughout the day. Now, when we think about formal leadership, I just want to quickly take a minute to take a look at some of the organizational models that are out there. The one in front of you is called the centralized organizational model. And as you'll see, that the decisions about nursing care and maybe the hospital are really driven from the top down, meaning that nurses do have an impact. However, decisions are made higher up in the organizational chart. Now, many organizations can have a mix of both centralized and decentralized. However, I encourage you to, when you're looking for a nursing job, is to ask about their organizational model and ask them how much of an impact you have, meaning the decisions that are made on the floor, and how the nursing care decisions are made. Because I do not want to work for an organization in which the CNO or maybe the chief nursing officer or the chief financial officer, the CFO, are making decisions for me at the bedside. You are the expert at the bedside, and you and a small group of teams should really be able to make decisions that are at the bedside that affect the patients. So when you're looking for a job, I strongly encourage you to ask about the decisions that nursing care affects. Are nurses a part of that? When we refer to management, we know that management really refers to activities involved in coordinating people, time, and supplies, and that's really to achieve outcomes for the hospital. And so when we think about ourselves, we're achieving outcomes and desires for the patients. And so we want the chief of staff and we want the medical directors involved for sure, because they're giving us oversight and problem solving and direction from the organization itself. However, I do want control over the nursing care and the evidence-based practice that's available to me. The other organizational model that I'd like to take a look at is called the decentralized organizational model, and this is the one that I strive for you all to ensure that you're hopefully, like I said, at some point they may have a little of both of these models integrated together. But decentralized really means that the decisions are made closer to the patient care. Like I said, if the patient is in the middle of that little diagram there, all of the people who are taking care of that patient, meaning pastoral care, respiratory therapy, we want their expertise and we want the decisions made closer to the patient, because the closer the decisions are to the patient, the more accurate and evidence-based practice they potentially will be. So each of those spokes will represent a member of the healthcare team, all directing its decision towards the center of patient care. As organizations do become more decentralized, like I said, activities are transferred from the chief nursing officer to the nurse manager or supervisor, or even to you, the bedside nurse. And there are many now hospitals that have committees that are taking a look at practice, leadership, and we'll talk about that in just a little bit. And that's really what you want to be involved in to ensure that your patients are being cared for properly. So when we look at decentralized organizational models, they really encourage autonomy and encourage evidence-based practice. There are even some facilities now that are starting to deploy a medical home model in the in the clinic setting, and that really is to get decisions made and supporting the full need of the family and patient involved. I'm not going to take a look at this. This is taken directly from your textbook, so you can take a look at it. However, I do strongly encourage that when you're looking for a job, that you really do consider the direct nursing manager or supervisor that's above you, and do your styles and their styles potentially match up. Preferably, you want to have a democratic or participative management style who's above you. People who are laissez-faire are often a hard time to follow because decisions are really never made. Things are a little ambiguous. What is the word I'm looking for? Ambiguous. And then on the other hand, the authoritative, the decisions are you often feel like you're micromanaged, which isn't good either. So let's take a look really quickly. I'm assuming that many of you understand levels of management, but we know that in a formal leadership, there are appointed positions, and they're given the authority. You are so naughty. I put that up there for a reason. Sorry. So they are given the authority to act really for the organization. But we have our first level managers, and these are really maybe even team leaders. Aspirus has now went to team leaders. I'm not sure what ministry has went to, but the first level leaders are usually visible on the floor. They do manage day-to-day activities, responsibilities to really motivate staff. They often visit with patients. They often perform maybe patient satisfaction. So they'll sit down and talk with the patients to ensure that things are going right, the patient's needs are getting met. They'll often round with staff and really find out what's working or what's not working. And sometimes they'll even staff the floor. Maybe they'll take the shift leader phone, or maybe they'll do staffing for the day. Oftentimes, first level managers are also involved with employee performance reviews and accounting for safe care, so making sure that falls aren't occurring, and if they are occurring, trying to understand what's really going on with it. When we move up to middle level, these are really supervisors more. They will supervise their first level managers, usually considered the head of units. So these guys may be supervisors or directors of the units, and they're really more involved with department-wide decisions. So they're involved with upper management so that they understand what's going on at the hospital-wide, and then trying to bring those decisions or not supporting decisions, trying to convey what the first level managers are seeing so that the upper management can make better or wiser decisions. But these guys, the middle level, are really more involved with decisions in the department as a whole. And then we have upper level, which are really the organizational executives. So the chief financial officer, the chief nursing the CNO, the chief nursing, my brain just went, whatever, you know what I'm trying to say, or potentially even the president of the hospital. So these guys are really in, those upper level executives are looking at how can we make the facility grow, Financially, is it equitable? Are we making money? If not, what can we do? What major maybe nursing initiatives can we put forward so that the organization itself grows to provide stronger nursing care, or even what potential services, meaning maybe we need to open up a congestive heart failure clinic. What services out there can we deploy to make our community stronger? When we take a look at this is also taken right from your textbook, so you can take a look at it, but really the management functions really are planning. And this is really no different. So we think of nursing management, but this is also things that you're going to be doing as a new nurse, right? You're going to have to manage your team. So you're going to have to plan, you're going to have to organize, you're going to have to work with staff, right? You're going to have to work with the CNAs, you're going to have to direct, and you're going to have to control them. But when we think of it from a management perspective, being first, second, or first, middle, or upper level management, these are some of the functions that they're doing. So planning, they're defining the goals and objectives of the unit or the organization. They're looking at policies and procedures. When I worked as a director for about 32 clinics, it was really important to I modified and reviewed many policies and procedures to ensure that we were providing safe care. For sure, determining resources, and then developing evaluation methods. When they're organizing, they're really looking at management structure, communication processes, and making sure that people are coordinating together so that the organization runs smoothly as a whole. For sure, staffing. So are we hiring appropriate staff? Do we have enough appropriate staff for the patients that we have, for the acuity that we have? If census is low, what are we going to do with staff? If census is high, where are we going to pull staff from? Definitely involved in the hiring process. And then when we think about directing, they're obviously encouraging employees to the goals and objectives of not only the unit, but also the organization, ensuring that their communication process is effective. And then I think that one of the biggest pieces is really motivating the staff. Sometimes I think that this is what higher level management sometimes can miss out on, is giving the compliments, giving the praise, making sure that people understand that they really are doing a great job. And when they're doing performance reviews, making sure that, when we did performance reviews, we always try to have at least 3 positives to 1 negative. Overall, people are doing the best job that they know how to do. People don't come to work, most of them at least, to do a poor job. So encouraging and motivating, I think, is essential if you're ever going to take a team lead role, supervisor, director role, really ensuring that the staff morale is high, because when employees enjoy their work and enjoy being at work, things go much more smoothly and patients are much more happy. Anyways, that's just a little side note. And then controlling is obviously performing employee performance reviews, looking at finances, looking at the quality of care that's being performed. So you can take a look at this. This is just a group exercise, and you can take a look. I'm not having it as a group exercise, but you can kind of write down some of the things that and I do think that this is important, because remember, like I said, you will be the leader. And I have always said in my whole nursing career that I would like to be treated as though people are treating, that didn't come out right. I want to treat others how I want to be treated. Sorry, it took me a minute. But find what are some leadership characteristics of a positive leader. Are they involved? Are they communicating effectively? And then on the flip side, I want you to take a minute and write down some negative leadership styles, because these are the things that when you start your nursing career, you really want to try to avoid. It's very easy to get frustrated to be upset at times, but you still have to maintain control and be an effective leader and try to stay clear of some of the negative leadership styles. And this may be even a good opportunity for you to write down some of your positive leaderships and negative leadership styles so that you can know you're aware of them and you can grow from them. Now when we look at theories, there is one theory that I like to discuss, and it's called the systems theory. And I do like this little saying here. It says that the manager that uses the systems theory makes decisions only after identifying and analyzing how other managers, units, departments, clients, and others will be affected by the decision. So systems theory is a type of organizational theory. It's much like the interdependence of our body. You know, we know that each system depends on each other for the whole entire body to function. My heart and lungs have to work cohesively in order for me to oxygenate and pump blood out. You know, and it's the same thing with systems theory. One decision made by one department or one manager will affect the system entirely and not just the decision on that unit. And this is really no different than even in a patient-nurse situation. We have to make sure that we're analyzing how the families, how it's going to affect them at home, how is the patient going to react, how are they going to be able to afford different medications, procedures, things like that. So systems theory is really a holistic approach, meaning that if one thing changes, other things are also going to be affected. So within a healthcare organization, we already depicted that all parts are related. So we know that each department and service is interdependent on each other, and that's really what creates the whole of the organization. And like I said, if one department or service is affected, then all of the parts of the organization are affected. So let's just think about an example. If we have an open system example, okay, let's say that the hospital is going to open up an urgent care, and that's going to help decrease the emergency room. We know that, so that's the internal change that's occurring. Now externally, meaning both outside of the hospital, or potentially even in the hospital, you know, that is going to affect how the hospital does business. Maybe insurance might be changed. Maybe the influx of patients in the ER is going to be changed, so staffing would need to be modified. Staffing may potentially need to be modified in the urgent care. Resources will need to be available in the urgent care. So both internal and external changes are needed to be made. Another example I think of is many years ago when I worked, maybe 15 years ago, I don't know, but if a patient came in with chest pain and they went for a heart catheterization, and let's just say even that the heart catheterization was negative and the patient didn't have any coronary occlusions, that patient would be brought up to CTU and they would spend the night, make sure that their femoral groin site looked okay, no hematoma, you know, good pedal pulses, vital signs were great. The next day they were sent home. Well, as the years progressed, insurance changed, and we know that for the best patient outcome, to keep patients out of the hospital is better. So there was a change that was, I believe in some aspects, started with insurance, but providers obviously at some point were involved, and insurances weren't covering the stay of the negative heart caths who received, or even some that were positive and they got a stent, they were being sent home that same night. So because of the insurance changing, the hospital, so that was an external stressor or an external change that occurred, okay? And in order for the hospital needed to be well aware of that, the chief nursing officer, the CNO, the president of the hospital, you know, they have to know what's going on. And so there was changes made to increase staff within the ACU or the ambulatory care unit. and they increased their outpatient hours. They, like I said, beefed up staff. But then on the flip side, the cardiac telemetry unit where I worked, we started to see a decline in patients because on average we'd have 12 to probably around 12 to 15 patients who would spend the night because of heart caths. So CTU census was down, ACU census was high, but another thing that affected that was they decided that, you know what, all congestive heart failure patients should be seen on CTU, cardiac telemetry unit, which only makes sense. So our census was able to stay up. So the whole point of me telling you that is that healthcare organizations are affected by both internal and external stressors, and it's very important that the leaders of the organization are constantly monitoring for these changes. And what I have seen over my 17-ish whatever years of being a nurse is that sometimes the nurses that are working on the floor don't always 100% understand why change is necessary. However, organizations don't change just to change. There are usually either internal or external forces that are asking them to change the way they do business. And so when you start your job, ask the questions, ask why, what is the impetus, why are we changing? It may be insurance purposes, it may be for the better benefit of the patient, maybe evidence-based practice, quality issues. You know, usually change should occur at least for the right reason. You can read the other example that I had put there regarding the prospective payment system as well. One thing, so hospitals are open systems, meaning they're affected by both internal and external sources. Healthcare systems are not closed systems. The definition of a closed system is that the system is totally independent of outside influences, and we know that that is not true at all. Healthcare organizations are affected by insurance, consumers, clinics, other entities that are outside of the healthcare organization. So know that healthcare systems are open systems, not closed systems. So you can take a moment to kind of answer these questions. Who has control over your nursing practice? Who determines what nursing evidence-based practice to adopt and implement within an organization? And really, what role will you have in leadership? And I think that these are important questions to just consider. Maybe take a few minutes and jot some answers down. You could pause the presentation. One of the big areas that I want everybody to try, not all of you are going to go to an acute care setting, and I know I speak of acute care setting most frequently, and that is because the majority of our graduates, the majority of nurses still work in an acute care setting, so I speak to that more frequently. But when you're going to interview and look for a nursing profession, I feel that a shared governance is really the ticket, is really the way to go. You know, from systems theories, the open system theory and other similar theories, really the shared governance theory evolved. And what shared governance really is it's a decentralized organizational model where decisions really are made closer to that patient care level. Decisions are made by the individuals who, like I said, provide the services to the patients or families. So it involves all levels of nursing. This could be an associate degree, a bachelor's degree nurse, an MSN, nurse practitioners, case managers, pastoral care, but it's all levels of the nursing and healthcare fields. Okay. Some of the common characteristics, you know, that it really promotes is autonomy and independence in the nursing practice. Accountability. If you are asked to provide the best care possible, then you need to be accountable for the practice, for your knowledge, to ensure that you are providing, and the others that are by you, other nurses that are on your unit, are also staying accountable to ensuring that their knowledge is to where it should be, it sure is empowering, right? If I knew that I had a say in the nursing care that's being provided, I am empowered to be the best nurse that I can be. It definitely needs participation and collaboration in order for shared governance to really work. Now, on your own time, you can go ahead and click this YouTube video. If you're on full screen, you should be able to view that, or you can open up the PowerPoint and you should be able to view that on full screen. So what are some of the advantages of shared governance? For sure, improve patient care because you're the nurses are making the decision. For sure, improved RN communication, and that will lead to increased job satisfaction and hopefully a decreased nursing turnover. Unfortunately, there's always disadvantages, and at some point it may be difficult to implement, especially when it's first developing. So if you're in an organization or are hired onto an organization where shared governance is more advanced, this may not be an issue, but sometimes it can be difficult for senior leadership to be able to relinquish some of the power that they have had, making it a little bit more difficult to implement. Some organizations may have various levels of implementation, and just like I said before, there may be a little bit of mixed centralized and decentralized type of organizational model, and that's what I was referring to with various levels of implementation. And then for sure, nurses have to be involved. So nurses who are knowledgeable, who are involved, who really want to move the organization and the nursing care in the right direction need to be involved. Now up on the top right hand corner of your screen, this is actually Aspirus's Coordinating Council model. And if you see, there's little spokes. One is for quality, practice, leadership, advanced practice, research, education. Those are all, there are 6 committees that nurses can be on, and usually 1 to 2 nurses are represented within each unit. And so they are looking at different perspectives of patient care, patient quality, the nursing practice, nursing leadership, all supporting the patient. And then at various times throughout the year, they meet for this coordinating council, and it is through this coordinating council and these committees that decisions for nursing are made at Aspirus. Now this is not something that you may get involved in right away, but it is something that I strongly encourage you to be a participant in, is that you're shaping your nursing career and the future of our profession. So you may not be involved right away, but know that there is always a say. You can go and talk to your leader, the representative that are on these various committees, and tell them your concerns or tell them your ideas. But be active and be involved to help shape our future. Now let's take a moment. We're going to move into nurse staffing. Now this should be pretty simplistic information, but we know that staffing is individualized to the organization and the unit, obviously. So when staffing a unit, staffing is really ensuring that the appropriate number and the mix of healthcare workers are available to meet the needs of the patient and to provide safe, effective care. So the focus really is that safe, effective care and ensuring that the appropriate number of staff per patient load is appropriate. And so what that often will depend upon is the intensity of the patient care. So a more complex patient may equal more nursing care, or that nurse having less patients because the complexity or the intensity of the patient care is that much more. Also looking at the geography of the patient care environment. There are times, I know that even on cardiac telemetry unit where I work, that you'd have to wrap a corner, and that's not conducive to making sure or monitoring and ensuring that you're always there in case something would happen. So that nurse may have less patients. Technology is definitely an impetus for this, in that, you know, if there is advanced technology that does help decrease error and also help deliver speedier care. And then for sure the preparation and experience of the staff. New nurses what a new nurse can handle versus a nurse who's been working for 5 to 10 years is obviously going to be different. And so when the charge nurse is looking at this, he or she will take a look at all of the staff and all of these different bullets to ensure that the teams are divided safely. Now, what I recommend when you take your first nursing position is that if a team doesn't look appropriate, doesn't look right, is that you speak up. You know, the charge nurses aren't foolproof. You know, they can make errors as well. So if something doesn't seem right, make sure that you speak up. But we know that staffing is individualized and that people have to make decisions on the spot, but the staffing in the intensive care unit is obviously also different than that in the medical unit. So nursing assignments, we know that for the most part, it's a patient classification or patient acuity system. So this is typically set from a higher up perspective, and nursing work assignments are, for the most part, budgeted on hours per patient day. So this is a patient classification system, which classifies patients according to this certain criteria and needs. And obviously, the higher the acuity, like I said, the more intense the RN needs are. When we think of hours per patient day, it's really the number of hours that are permitted or allowed for a nurse to spend with a patient within that 24 hours. And this is usually calculated by the average census of the unit. So let's just say, for an example, if the unit census is 25 patients and management has given the unit hours per patient day of 7, they would take 7 hours times 25 patients to equal 175 hours for that whole day. And so 175 hours of nursing care would be able to staff the unit for that day. Now, this isn't something that you need to be 100% concerned with. As a staff nurse, just know that, you know, there may be times when the unit isn't full, and what that sometimes will mean is that nursing staff, CNA staff, unit clerk staff are asked to go home. And that's just because of the fluctuation of patient census and how it's calculated for the budget purposes. Anyways, all right, so lastly, I'm hoping that you all know this, that the scheduling patterns differ. There's full-time, part-time, occasional. There's 8-hour shifts, 10-hour shifts, 12-hour shifts, and you may be on day, PM, night, or variable shifts. Now, when I first became a nurse, I actually worked 3 12-hour shifts a week. I worked 3 in the morning and until 7, or 3 in the morning till 3 in the afternoon. And I know some of you out there are probably like, oh, that's a terrible shift. But I tell you what, when you first become a nurse, the really, really busy shifts will be hard to learn, will be hard to grow, and sometimes not always making you feel as confident as maybe you should or maybe even shouldn't be. But when I worked 3 in the morning until 7 in the morning, I was able to have time to look up my patient information, review their H&Ps, review their labs, know what was normal, review their echocardiograms or chest x-rays, review all of the information I needed to, so that when the provider came around in the morning and asked me questions, I was confident and I was ready and felt okay to take care of those patients. Now, not all of you will be granted that time. And I know that most people always want day shifts, but I assure you that day shift is definitely more stressful than a PM or night shift. So you just really need to do what's best for you, and to also to see what is offered in regards to the position. So this is just some discussion that I would like you to consider and maybe answer. But as a future charge nurse, you will deal with a short staff. How will you deal with short staffing situation? And what assessments would you need to perform as the leader? So just take a few minutes and you can jot some things down. This may help you in the future. So take a few minutes to just think about these questions. Now, when we also think about management and leadership, we want to also be thinking about quality patient care. And when you're going to interview for different jobs, I also think that it's important that you understand how the organization is accredited, who the agency is through. But the Joint Commission on Accreditation of Healthcare Organization is one of the largest accrediting bodies, and they do have to there is a huge manual and many criteria that organizations have to meet. When I was working in that director position for the clinics, Joint Commission had to visit that and within the time that I was doing my role. So prior to Joint Commission coming, there was a lot of pre-work ensuring that, all the staff were abiding by the codes and all this great stuff. And then during, they usually come for 4 days, 3 to 4, sometimes even 5 days, and they're really doing a full, thorough inspection on the organization to ensure that they are meeting the expectations in order for Joint Commission to give their stamp of approval. One thing that you will notice is that Joint Commission does every year puts out a national patient safety goals. I did put this in Blackboard, so it would be good for you to take a look. But for 2015 at least, it was to identify patients correctly, improve staff communication, use medication safely, use alarms safely, prevent infection, identify patients' safety risks. I'm sorry, I had to pause it, so if I repeat myself, I'm sorry. So identifying patient safety risk and then preventing mistakes in surgery are the areas that they've identified for their national patient safety goals. And each year, these do change. However, a lot of times I have seen most of these kind of repeated yearly. So you will hear information about this at the organization, and you may or see signs regarding the national patients safety goals. All right, so let's talk about managing and promoting change. There is one thing that I have found in my nursing career, two things actually. The first, just as it says, change is inevitable in healthcare. We know that the care that we're providing today is definitely going to change, and we need to be advocates for change to ensure that we are providing the most current, up-to-date, evidence-based practice that we can. We also know that change is most often planned, but it can be unplanned. And the rules there to follow for change really should occur, that change should only occur for a good reason. Change should be planned and implemented slowly. Change should never be unexpected or abrupt, and all people affected should be involved. What I've seen occasionally is that organizations, whether it's healthcare or business or whatever, is that there's knee-jerk reactions, and that often doesn't work. I mean, you have to be thinking ahead and really trying to see what's going to be in the best interest for myself, for the organization, for the other nurses around me, and that the change is good and that it's planned and that everybody that's involved in the outcome of the change or the planning of the change really needs to feel like they are connected to the change in order for the change to be successful. When I've seen change not be successful, it is usually because one of those are not done correctly. I've also noted that, really too much change can be difficult to deal with, and it often can lead to like doubt or, people around you are like, what are we always changing for? We don't even get to see the results of one change before we have another change. So then we often start to see resistance to change. So resistance to change, what I've found is that there are really typically three types of people. There are people who accept change, people who are like change agents, that's kind of what I think of, people who resist change, usually because at some point in time they feel threatened about what the change is going to be. Or there's these fence sitters. And what fence sitters are is they really just watch and wait, and they kind of react to those around them. If it looks like it's going good, they'll be like, yeah, that's great. Or if it looks like it's going bad, they'll be like, no, I told you that was going to be bad. So when we think about resisting change, I think that we can all probably think back and know that at one point in time we have resisted change. And usually it's because we're the satisfaction, the way we've done it is always the way we've done it, and it's the right way. So sometimes they don't realize, or individuals don't realize, that there's a better way to do things. Um, Also because it threatens their self-interest. Maybe they don't want to come in 10 minutes early because of the change, or maybe it's going to add an extra step if we do something different with the IV dressing change. Um, Maybe it's a misunderstanding or a misperception. Some people just have a fear for changing. Some people have a low tolerance to change. Sometimes it's just wrong timing, like I said. If there's too much change going on, at some point in time people will resist change because they can't see through all of the changes to what the end goal is going to be. And then for sure, the lack of information can definitely be a resistance to change. So then let's take a look at how do we decrease resistance, because at some point you are going to be a change agent, and whether that is because you're working on the floor and you're working with the CNA and you look at the way she or he's doing something and you enact a change for them, or you encourage something different. You will be a change agent whether you're in a formal leadership role or whether you're working on whether you're the lead of your own nursing team. There will be things that you see that need to be changed. So how do we try to decrease resistance? First off, plan, 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 and communicate, communicate, communicate. I think are the two greatest things that a change agent or someone that the staff trusts, and motivate people really is going to help decrease resistance. I think the next biggest thing is to confront resistance. When you're starting to see somebody who's like, I'm not doing it that way, and you've asked a CNA, you say, you know what? When taking out the IV, I noticed that you're not looking at the end of the catheter. There's been education, you ensure that they've had it, and the CNA says to you, I'm not doing it that way. Well, as the leader of that team, you really need to confront resistance. Why? Why? Tell me why. Maybe it's a lack of misunderstanding. Maybe it's a lack of training. So confronting resistance is probably another big ticket when resistance is noted. Next, we want to make sure that we're discussing both the positives and negatives or consequences that can or could occur if the change isn't implemented. If it's not something emergent, we want to try to introduce it gradually, and making sure that we educate staff around the change. Communicating, we talked about. Clarifying, so that goes kind of with educating, making sure that the individual fully understands what's being told and that they're well educated enough to be able to perform the change or entrust that the change will be beneficial in the future. Sometimes if it's a big change, you may need to implement some incentives or get some extra support involved. But always use a change agent, and many times you will be the change agent. So what I want you to do again is just to take a minute and think about, how do you most commonly respond to change? And I think that when we think about how we respond to change at home versus how we respond to change at work or in different environments, we do respond differently. Some places were easier to adapt, whereas in other locations were not as easy to adapt to change. So I think that before you can be a change agent, you have to understand you and how you react, because just like nonverbal communication, Change is much like that. If you're not a change agent, trying to then become one can sometimes be difficult. And I also think that life events can alter how you change and how you respond to change. I know that when I first began my nursing career to now today, how I evoke change or accept change, it is different. You learn as you grow and you experience, and you learn how to communicate and better instruct and educate and ensure that people are riding the same bus as you. Some of you may be further on that train than others, but it is important to understand how you respond to change and how things have affected you in your life. So when we think about planned change, we know that a nurse must understand the change theory to be really that effective change agent. So within that change agent, he or she plans, guides, encourages, and controls change through adaptation and facilitation. Now, when we think about planned change, it's not only in your leadership role that you're going to assume once you leave this nursing education platform, but it's also going to be how are you going to help the patient change? Because for the most part, patients are sick or ill because of something they've done. Maybe they have COPD because they smoke. They have coronary artery disease because they eat cheeseburgers. They have congestive heart failure because they eat buckets of salt. They're diabetic because they're obese and they don't exercise. So being a change agent is not only important for your leadership role for your nursing team, but also your leadership role in being able to actively engage patients and family in creating the change to better health care. So one model I want to take a look at is by Lewin's, I'm sorry. He was from the 1950s, and he introduced this model of change. So to be successful, 3 phases of change must occur. First, you need to unfreeze, move, change, and then refreeze. So it is necessary to identify the forces that will assist and the forces that will act against the change. And this is completed by identifying the driving and restraining forces. In this model, typically the driving forces must be greater than the restraining forces, right? So the reasons why the change needs to occur are greater than the reasons not to change, or the driving forces have to have a greater impact than those of the restraining forces. And we'll run through a little example here in just a minute. So each person that is going through this change, or the organization potentially undergoing the change, must pass through the changes through all 3 of the phases of change in order for the change to be successful. So when we look at unfreezing, which is the first component, it's really developing an awareness to a need or problem where change is the only solution. And during the unfreezing, like I said, it's identifying the driving and restraining forces. So this stage is really about getting ready to change, and it involves getting to a point of understanding that change is necessary and getting ready to move away from the current comfort zone. The second biggest point, I think, is that people must first believe that improvement is possible before they're willing to consider change. But know that oftentimes the unfreezing phase does make people uncomfortable and anxious, and so a lot of clear communication and getting everybody involved is required. So when we think about those forces that I just said, the driving forces are really defined as the forces that assist the change to occur, whereas the restraining forces are forces that prevent the change from occurring. So part of the change agent's responsibility within this unfreezing phase is definitely gathering the information about the problem, assessing the problem, really deciding if change is necessary first and foremost. Sometimes we think change is necessary, and maybe something just needs to be tweaked a little bit. Okay? Then we're going to identify options and resources available, look at those driving and restraining forces, and then inform others or gather the input from all involved for the need for change. We then would move in, once we decide that yes, change is necessary, we then want to take a look at moving or the changing phase. So these are the driving forces that we've identified, both the driving and the restraining, but the driving forces will prevail and a new way is presented. Now remember that communication is key to this. Everybody who's involved in the change really should at some point in time be involved in helping create or drive the change. The more people you get on board with your change, the easier the change will be. So if we were thinking of, if we were dealing with a patient who smokes, right, then making sure that we identify with the patient, the family, or whoever is involved living with that patient is involved with both identifying driving and restraining forces, ways in which we're going to move towards change, and setting goals and objectives, talking about target dates and implementing the change, educating, being able to help and support and evaluate the change and make modifications. So the change agent responsibilities are really listed on the slide, so you can take a look at them. And then the last phase of this is that refreezing phase. So the change is now implemented, but it needs to be stabilized so that it becomes the new way of life. If freezing is not completed, what usually happens is people are creatures of habit, right? And people will drift back to their old ways of doing things if the refreezing phase does not occur correctly. But in order for the refreezing phase, the normal functioning must resume and it must become a routine. And oftentimes, the change agent also needs to identify those who maybe the refreezing phase isn't going as well as others and help support and motivate them to be able to get through the refreezing phase. So that's where I have as guidance and support is needed from the change agent and identify support persons. So if you're sending a patient home and you want them to stop smoking, you would identify support people who would encourage them or be their change agent when you obviously are not going to be around because you are in an inpatient maybe setting. So other responsibilities within the refreezing phase is to require and enforce compliance with the change process, support and encourage the individual, follow up and then also reevaluate as needed. So here's just an example. So you're caring for a 54-year-old male who was recently diagnosed with COPD. Unfortunately, he continues to smoke. He states he doesn't wish to quit. He's under a lot of stress at work. His friends smoke, and it's all he knows, which is pretty common. His family keeps harping on him, but he refuses to change. So I want you to take a few minutes and try to figure out what's the problem. When we think about unfreezing, what are the driving forces for him to stop smoking? What are the restraining forces for him to stop smoking? What are you going to do to move or change or set goals and objectives? What would those look like for this individual? And then what will you be doing in that refreezing phase, or who would you be ensuring is following up with that refreezing phase? So take a look, try to run through this activity on your own. I don't have any answers. Well, I do, but I'm going to let you guys work through them. All right. That is all I have for you on managing a nursing team. There are some questions here that you can take a look through on your own. And if you have any questions, you let me know.